Morning everyone. Today we are going to discuss the female urology and functional urology topics for urology Viva exam preparation. We are going to discuss three scenarios. We are going to time every scenario by the clock 10 minutes. I will not interfere with the trainee during the 10 minutes, so it will be exactly like an exam. And after the 10 minutes, we will have some feedback and discussion on how that scenario went well. Happy to start?
Yes, please.
Okay. Keep your mobile muted because I may be sending some messages during the session as a feedback.
Yeah.
Your time starts now. You
Yes.
have a 28-year-old female presenting with history of pain while passing urine. How are you going to evaluate?
So I review this lady in my female dedicated urology clinic. I will assess the patient history, concentrating on the pain while passing the duration, and whether the pain is on emptying of the bladder or on bladder filling. I will also ask about any associated lower urinary tract symptoms like voiding or surge urinary symptoms, any presence of incontinence. I would also ask about any obvious triggering or relieving factor from the history, about any red flag symptoms like hematuria, urinary tract infection, or the presence of palpable mass. I will also ask about the patient drinking habit and any smoking or illicit drug. And also, I will ask about her past medical history and the use of any medication, past surgical history, especially any urological procedure, any pregnancy or childbirth before, and also about any history of radio chemotherapy. I will ask about whether there is any impact of this pain on her social life or sexual life. And then I will do a focused examination in the presence of a chaperone with the patient consent, general examination looking for any palpable bladder or tenderness in the suprapubic area. And then I will examine the patient perineum, both in supine and left lateral position on inspection, looking for any visible abnormality like urethral caruncle or urethral diverticulum, any prolapse, the degree of sterilization of the external genitalia. I will ask the patient to cough to see if there is any leak, and I will complete my examination by speculum. And then I will assess the patient accordingly.
Okay. History-wise, there is nothing significant. She is married. She has one child, and the child born by normal vaginal delivery. Examination uneven full. Her BMI is 28, but abdominal and pervaginal examination were normal. How are you going to proceed?
So her main complaint is just pain and passing urine.
Yeah.
Okay, and there is no history of use of any illicit drug, any ketamine or anything.
No.
Okay. So I will proceed by checking the urine, looking for any infection or blood in the urine. I will send a culture if there is anything suspicious in the urine dipstick. I will also arrange for the patient to have, especially if the symptoms persist for a while, I will arrange for her to have a flexible cystoscopy. Looking for any possible cause for this pain associated with urine. And also I will arrange imaging in the form of urinary ultrasound.
Her ultrasounds were normal. Flexible cystoscopy is normal, but she find it quite painful during insertion of the scope and also the filling of the bladder.
Yeah, and this patient, if obviously I couldn't find any any positive finding in my investigation or in the history. So therefore, my suspicion is painful bladder syndrome or interstitial cystitis, which is mainly a diagnosis of exclusion. And according to the International Continence Society, any chronic pelvic pain, pressure, or discomfort related to the bladder associated with one or more urinary symptoms is a diagnostic for painful bladder syndrome.
Okay, what is painful bladder syndrome?
It is a chronic condition affecting the bladder, mainly in the form of pain related to the bladder filling or emptying, and may associate with other urinary symptoms like frequency, urgency, and nocturia. The exact etiology is unknown, and it's usually diagnosed by exclusion of other causes of chronic pelvic pain. The pain may be perceived by the patient in the bladder, in the urethra, in the vagina, rectum, or in the back. The etiology is not clear, but they think that there is loss of the protective gag layer from the bladder, which causes permeation of the urine inside, and then it will induce further irritation of the bladder mucosa, and then the patient will enter into a circle of event related to that.
Okay, so how are you going to proceed further?
So for this patient, I will assess her symptom further using a validated questionnaire. We have the interstitial cystitis symptom index and interstitial cystitis problem index. Each one of them ask mainly about four main domain, which is the frequency, urgency, nocturia, and the pain. So I will assess the patient according to these. I will make sure that there is no infection. I have excluded other causes from the history. I will start the treatment of the patient by conservative treatment in the form of education and explanation for the patient about the nature of the disease, that this is a chronic disease which will wax and wane over time, and the patient should have a realistic expectation. I will support the patient by referral to a pain clinic, or provide a psychological support if it is needed early in the disease. And then I can take her management forward accordingly.
Okay. What is the total score for the interstitial cystitis scoring system?
For the IC symptom index, it is 20, and for the problem index, it is 16.
So what are all the components of the problem index?
It's an answer for the same question, which is the frequency, urgency, nocturia, and pain. But the answer will be either no problem, small problem, problem sometimes, or severe problem, as far as I can remember.
Okay. Her symptom score comes as 16, and her problem index comes as 14. How are you going to proceed further?
So for this patient, obviously because of significant symptoms, she needs to have some treatment in addition to the conservative therapy. If I can add just to the conservative therapy, I will ask the patient to keep a diary for all the fluid, for the oral fluid and food which may trigger the problem, try to avoid it. And then, since her symptoms persist, I will start with medical treatment. Medical treatment, we have two types, either oral or intravesical treatment. The oral treatment include amitriptyline, antihistamine like cimetidine, and also sodium pentosan polysulfate Elmiron, which thought to replenish the gag layer in the bladder. The intravesical therapy, I am aware of the use of ialorel, which is a combination of chondroitin sulfate and hyaluronic acid. It can be given as instillation inside the bladder once weekly for 4 to 6 weeks, and then maintenance once monthly for 4 to 6 months. Some cocktail have been used before, like the Parson cocktail, which is composed of heparin, bicarbonate, and dignocaine, can be tried on those patients. So I will go to the next step, which is the medical treatment.
Okay, how this hyaluryl works?
The hyaluryl is a combination of chondroitin sulfate and hyaluronic acid, which are both component of the gag layer in the bladder. So they provide a protective layer above the bladder mucosa and reducing the symptoms.
Okay, is there any oral available medications?
The main oral medication, we can use amitriptyline, especially if the patient having pain and anxious. The one which is proven to be effective in reversing the process of interstitial cystitis is sodium pentosan polysulfate, Elmiron, which is given as 100 milligram 3 times daily. However, it is not available all the time and it is a little bit expensive.
Okay, we will stop there. Again, good presentation. I have no major concerns. Everything went well. I mean, if I really comb across your presentation and try to pick something, maybe obstetric history. You haven't brought it yourself. Sometimes a vaginal injury can happen with vaginal delivery, and that may be the reason for the pain. So, obstetric history, how many children, by which way the child was born, whether it's a vaginal delivery or cesarean. Vesical cystoscopy findings are very important. I said that insertion of the scope was very painful and bladder filling was also painful. But during subsequent sentences, you mentioned that flexible cystoscopy and ultrasound, everything was normal. So don't try to ignore the findings. That painful itself is enough to give you a kind of an insight. Okay, this may be something like interstitial cystitis or chronic pelvic pain syndrome.
Okay.
Yeah, because to get the proper glomerations, you may have to do a cystoscopy under GA. So under local, the pain itself, of course, there is a lot of subjective changes. Patients may complain pain without any reason. It may not be IC, but that every small clue will help you. And there is a European study group on interstitial cystitis, which is they have produced some journals, articles, and then that they also use the same IC questionnaire. It is nice to use the ICIQ, the international questionnaire, what we discussed, but try to bring in the European study of interstitial cystitis consensus guidelines also.
Okay.
And I like the way you presented the realistic expectations. That's very important because patient may think, okay, I have this pain, I'm going to see the doctor, he's going to give me a medicine, and then I'll be fine in a week's time. This is not that type of disease, so it's very important to have realistic expectations and gradual, slow improvement and possibility of long-term treatment. Symptom index, you made it very simple. That's the way it has to be. Four things: fun and pain. Fun means frequency, urgency, nocturia, the normal storage symptoms, and pain. Everything is coded up to 5. Only in the pain there is no score 1. If you want to score quite high marks, if you pick that specific points, like for pain in the symptom index there is no score 1. It's only 0, 2, 3, 4, 5. Rest of them we have 0, 1, 2, 3, 4, 5. Problem index, again it's the same, fun and pain. The only thing we are quantifying the problem. It's almost like a bothersome index in the IPS scoring. And remember, no problem, very small problem, medium problem, big problem. If you remember, don't miss the very small problem. If you miss very small problem, you can't get that 0, 1, 2, 3, 4. And no problem is 0. That's very important. Similarly, in symptom index also, if the symptom is not there, it is 0. So always start scoring from 0, not like IPSS. So compare and contrast so that you can remember better. These scenarios, if somebody is not strong in IC symptom score index, they will still get good marks. But if you are strong in this scoring system, if you have demonstrated that you have used it in day-to-day life, that will really fetch you very, very good marks. Okay?
Okay, thank you.
Good. Happy to start the next scenario.
Yes, please.
Okay, your time starts now. You have a 55-year-old female presenting with history of difficulty in passing urine, and she seems to be straining for the past few weeks while passing urine. Otherwise, no other symptoms. How are you going to evaluate?
So I will review this patient in my dedicated female urology clinic. I will assess the history regarding the onset and progression of difficulty in passing urine. I will ask about associated any storage urinary symptoms associated with the voiding symptoms. I will ask about any associated pain with that, ask about any red flag symptoms like hematuria, recurrent urinary tract infection, any palpable masses. Also, I will ask about any associated incontinence, whether stress or urge incontinence. Also, I will ask about her any previous urological procedure, especially any surgery done before for prolapse or for urinary incontinence. Also, I will assess her in the past surgical history. I will exclude any history of radiotherapy or chemotherapy previously. I will ask about her obstetric history regarding number of pregnancy, childbirth, use of any instrument. I'll ask about her previous medical history and the use of any medication, especially if there is any neurological disease. I'll ask about the social history, including smoking and the use of any illicit medication, and the effect of her symptom in her daily life and sexual life. And then I will proceed to examination of the patient in the presence of chaperone with the patient consent, looking for any obvious neurological, any sign of neurological disease. And then I will examine the patient looking for any palpable bladder or bladder tenderness, examination of the perineum in supine and lateral position, looking for the shape of the urethral meatus, if there's any obvious abnormality in the urethra, like urethral caruncle or urethral diverticulum. If there is any degree of prolapse, the degree of externalization of the perineum and the genitalia. And also I'll ask the patient to strain and cuff to see if there is any leak of urine, and I'll complete my examination by speculum examination.
Okay, what type of speculum you will use?
I will use the Simpson speculum.
Okay. Her history is quite straightforward. She has no past medical or surgical illness. She has three children, all born by normal vaginal delivery. She is postmenopausal for the past 2 years. She has no major concerns with sexual health, not a smoker, and no significant medical history in the past. Examination wise, she is obese. Her BMI is 36. Otherwise, examination findings were normal. Genital examination, on inspection, you're able to see a bulge in the urethral meatus in the anterior vaginal wall. Otherwise, no urine leak. Sim speculum examination uneventful. How are you going to proceed?
So in this lady, when I see a swelling in the anterior vaginal wall, then the suspicion is possibly urethral diverticulum. However, I would expect urethral diverticulum to give her some symptom in the form of dysuria, tripling, and dyspareunia. The patient is asymptomatic.
No, she presented with blocking sensation while passing urine.
Okay. Okay, that's fine. So my suspicion from the examination is the presence of urethral diverticulum. I will confirm my suspicion by doing an MRI scan of the pelvis, which will confirm the diagnosis.
Okay, I will share the MRI scan. So this is the MRI scan. We are seeing the axial T2. I'll take you, are you able to see it?
Yeah.
Yeah, I will take it from bottom to top. You can stop me if you want anytime.
Thank you.
And this is the sagittal pictures. Any findings?
Yeah, so I can see from the MRI that there is a suspicion of urethral diverticulum more toward the left side of the urethra.
Okay.
So in this case, I will discuss with the patient the need for treatment to improve her symptoms. I will explain that the treatment will be surgical by excision of the cyst. I will explain to the patient the procedure in terms of technical aspect and possible complication. As the alternative, I will support my consent with the Bow's leaflet. I will explain to the patient about the possible complication, including urinary incontinence in about 10 to 20% of the patient, recurrence of the cyst in about 10%, and very low possibility of fistula formation after the cystic excision. I will explain that she will need to have a catheter for a few days after the procedure, and the procedure will be done under general anesthesia on day case basis.
Okay. How will you reconstruct the urethra again?
Usually, if the cyst size is not that big, direct closure of the urethra is possible. If it is difficult, then I will use the Martius labial fat pad flap in order to augment my repair.
Okay. What is Martius flap? What is the blood supply?
So Marshall's flap, it is a fat pad flap taken from the labia. It is based on a branch from the internal pudendal artery. So we do an elliptical incision on the labia, release the fat pad, and then we insert or interposition the fat pad in between the urethra and the anterior vaginal wall to augment the repair.
Okay. So how will you explain this surgery to her?
So I'll explain to the patient that she will be put to sleep and then we'll open the legs. We will insert a urethral catheter and then an incision in the anterior vaginal wall will be done. The urethral diverticulum will be excised completely and then the urethra will be closed by absorbable stitches. And then another catheter will be inserted, left in for about 4 days, and then she will come back. We'll take the catheter out. She will notice a little bit of pain after the procedure, blood in the urine for a while, which is universal for most of the patient. The specific complication is a low possibility of recurrence, low possibility of fistula formation, and there is a possibility of urinary incontinence in about 10 to 20%.
Okay. What is the long-term follow-up for these patients?
For this patient, I will send the diverticulum for histology all the time to exclude the very low possibility of malignant changes. I will see the patient in the clinic after 3 months to assess if there is any pain, discharge, difficulty during sexual intercourse. I will examine her urine, assess her flow rate and post-void residue to make sure that everything is fine.
Good. And what kind of cancer possible?
I think it's possible to have adenocarcinoma in the urethral diverticulum.
Okay, we'll stop there.
Thank you.
You did really well the second scenario. I have nothing much to add. So urethral diverticulum is a scenario. Mainly, you should be very confident in the surgical steps and Martius flap reconstruction. They won't expect too much, but identifying is important. Usually, the MRI scans or any investigation shown in the exams were quite straightforward. Sometimes they can say a picture of the perineum showing the diverticulum creating a bulge, and those are all the possibilities. Quite straightforward scenario. You have any questions on this?
No, thank you very much.
Can we go for the next one?
Yes, please.
Okay. You have 21-year-old lady married 3 months back, presenting with history of urinary frequency. How are you going to proceed?
So I will assess the patient history regarding the severity of the frequency, whether associated with any urgency or nocturia, any incontinence associated with that. Is there any difficulty in emptying the bladder, any voiding symptoms? I will ask about any dysuria or discharge. Ask about any red flag symptoms like hematuria, recurrent UTI, or any palpable masses. I will ask also about any triggering factor for her symptoms, anything in the food or drink she noticed which precipitate the frequency. Also, I will ask about her medical history, any history of diabetes or neurological disease, any use of medication. I will ask about her past surgical history and urological procedure before. And I'll ask about whether she had any previous pregnancies, any childbirth, and any use of any assisted delivery. I will ask about social history, the use of any illicit drug, the smoking, and the impact of her symptoms in her life and sexual life. And then I'll proceed to examination of the patient. I'll examine a general examination, including the BMI. I will assess the patient abdomen looking for any palpable mass or tenderness, and I will examine the genitalia, both in supine and left lateral position with the help of some speculum. I will get urine dipstick to assess for any infection, blood, glucose, or protein. I will send the sample for culture if there is any infection, and I will ask the patient to fill a validated questionnaire, which is ICIQ F LUTS. And I will ask a patient also to perform flow rate and the bladder scan since she's in the clinic.
Could you explain ICIQ for LUTS?
So this is a validated questionnaire by the International Continence International Consultation on Incontinence Society, concentrating on the lower urinary tract symptoms specifically in females. So it is different from the IPSS, which is mainly designed for the male. And it contains, I think, about 13 questions.
Okay. Do you know anything like severity? How will you quantify a patient got severe or mild, moderate?
I'm not quite sure, but the ICIQ, they have a separate Butler score for each urinary symptoms, not like the IPSS, which has a Butler score for all the symptoms at the end.
Okay. This patient has got quite bothersome symptoms. Her main problem is frequency of urination, no signs of any incontinence, married for 3 months, no specific problems with sexual history, no past history of any obstetrics. Her menstrual cycle is irregular, no history of any medication intake, social life, she is not a smoker, and no increased intake of alcohol or no history of any drug intake. Examination wise, she is thin built. Her BMI is only 24 with examination being normal. How are you going to proceed?
So in this patient, I'll assume that her frequency may be an element of overactive bladder symptoms. So I will I will start by conservative therapy by asking the patient try to avoid any fluid or food which trigger her symptoms. Pelvic floor exercise and bladder training as recommended by EAU for at least 6 weeks may be helpful for the patient. And then I will review the patient again in 3 months' time. If she's still symptomatic, then I will start the medical treatment.
Okay. You are advising the lifestyle changes. She is trying to diligently follow it, but not much improvement, only minor improvement. And she also developed urgency sensation, and she's quite bothersome.
Okay, so I will start then with the medical treatment in the form of anticholinergic medication. So I will prescribe her, I will start her on anticholinergic medication with the lowest acquisition cost according to the NICE recommendation. I will explain to the patient that she needs to use the medication for at least 4 weeks to have the maximum benefit. I'll explain about the possible side effect, including dry mouth, constipation, blurred vision, and I'll make sure that the patient has no contraindication for anticholinergic.
So, what type of anticholinergic? What dose you're starting?
I will usually in my practice, I prefer, I know that oxybutynin and tolterodine are the cheapest. However, in my practice, usually I start with solifenacin, 5 milligram once daily, since it is a selective one and has a good clinical result. So I will start on solifenacin 5 milligram once daily, reviewed by the GP in 4 weeks. If there is a partial response, then he can increase the dose further to 10 milligram.
How will you explain the side effects of solifenacin?
The main side effect is dryness of the mouth, constipation, blurred vision, and palpitation. So these are the main things.
Okay, why that side effects happens?
It's mainly because solifenacin acts mainly on M2, M3 receptors in the bladder. However, it may affect other muscarinic receptor in the body, so causing these symptoms.
Okay, you are seeing her in 3 months' time. She had increase in the dose of solifenacin to 10 milligrams by the GP. She is quite troubled by the side effects of constipation and dry mouth. She needs to discontinue the tablet and she is back to square one with symptoms.
Yeah, unfortunately, this is not uncommon because of the side effect profile of the anticholinergic. A lot of patients, they drop the treatment. So in this case, I will counsel the patient about the use of mirabegron, which is a beta-3 adrenoceptor agonist.
So, what is beta 3? How it works?
So basically, it is adrenoceptor agonist act on the beta-3 receptor, which is supposed to relax the detrusal muscle. So it decrease the sensitivity of the detrusal muscle to calcium. Therefore, it causes detrusal muscle relaxation without affecting, so it will increase the capacity without affecting the contractility of the detrusal muscle, unlike the anticholinergic medication, which will affect the contractility.
Okay, how are you going to explain the side effects?
So for mirabegron, the main thing I want to make sure that the patient is not known to be hypertensive, and I will check her blood pressure, since the main concern is uncontrolled blood pressure. Any patient with a blood pressure systolic more than 180 or diastolic more than 110 millimeter mercury should be excluded from mirabegron. I will check her blood pressure before starting the treatment, and then I will follow the blood pressure regularly through the GP to make sure that mirabegron is not affecting her blood pressure. The other rare side effect of mirabegron is a little bit increase in the rate of urinary tract infection, and it may cause palpitation as well in some patient. I am aware of a new version of beta-3 adrenoceptor, which is vibegron medication, 75 milligram, which is used and approved in the US. And this one is not associated with hypertension, but it's still not approved in the UK.
Good. She responded well to mirabegron and you have discharged her. She presented after 2 years with recurrence of symptoms in spite of taking the tablets. How are you going to evaluate?
I will reassess the patient again by having a complete history examination, as validated questionnaire, urine analysis, flow rate, and bladder scan. And if the symptoms are similar to the previous one, I will just restart the mirabegron again for the patient.
She is taking mirabegron regularly, but in spite of mirabegron, she has got the recurrence of symptoms.
Sorry. So she was using the mirabegron for the last 2 years, but in spite of that, she still has some symptoms.
Yeah.
Yeah, so according to the European guidelines, EAU guidelines, we can combine mirabegron with anticholinergic medication in order to get the maximum symptomatic improvement, and this is supported by the Synergy 2 study, which showed safety and efficacy of sulfenacin 5 milligram and mirabegron, which was used for more than 12 months.
Oh, she remembers the solifenacin side effects of dry mouth and constipation. She's not interested in that.
Okay. So, and we can try another anticholinergic medication, which may have a little bit some different side effect. However, if she is not keen to try the anticholinergic at all, then I will discuss with the patient that since mirabegron alone is not enough to control her symptoms, then we may need to move to more invasive treatment for her overactive bladder.
So, what are you going to do?
So in this case, the next step is to consider intravesical Botox injection. I will arrange for the patient to have a urodynamic study before to see whether there is any detrusal overactivity or not. I will discuss her case in the local urogynecology MDT, and then I will counsel her about the use of intravesical Botox. I will explain mainly about the need to learn how to do self-intermittent catheterization and about the some other side effect of Botox therapy.
Okay. Are you able to see the screen? Can you explain the tracings?
Yes, so this is a urodynamic study of a patient which showed, so the top one is the detrusal, vesical, and abdominal. Okay, which showed some detrusal overactivity, very obvious, reaching up to around 60 centimeter water, and also I think that the bottom one is not clear, but I think this is the flow. So some of these bladder overactivity associated with some urine leak as well,
Yes.
which goes with detrusal overactivity. I will check from the history of the patient to see whether she had any neurological disease. Then it will be a neuropathic detrusal overactivity. Otherwise, it should be regarded as idiopathic detrusal overactivity.
Okay, there is no neurological problems for her. How will you differentiate between detrusor overactivity and leak due to abdominal straining?
In the leak due to abdominal straining, there will be a rise in the abdominal pressure as well, which is not the case here. So the abdominal line is almost stable, while the rise is mainly in the vesicle and the detrusor. So these are genuine detrusor contractions.
Okay, so what are you going to do for her?
So for this patient, there is a proven detrusal overactivity, which an obvious indication to go ahead with the intravesical Botox injection. So I explained to her that the procedure can be done under general anesthesia or local anesthesia, and we will inject about 20 sites all over the bladder with the Botox. The expected side effect in most of the patient that there will be some dysuria and hematuria for a few days after the procedure. There is incidence of UTI about 10%. There is a possibility of urine retention, which is about 6% for each 100 international units, and the patient need to be confident in using self-intermittent catheterization before we start the treatment. I'll explain that the effect of Botox will wear off within 6 to 9 months, and we may need to repeat the dose again.
Okay, what are the why you want to do the intermittent self catheterization?
Sorry?
Why intermittent self catheterization before Botox?
Because the patient may develop urine retention, and she need to be confident in doing self-intermittent catheterization before we start. If she is not willing or unable to do the self-intermittent catheterization, then I will not consider Botox for this patient.
Okay, well done. It's time now. We have slightly overshooted to 11 or 12 minutes because I just want to bring out the Botox also in the discussion.
Thank you.
Again, well done. No major concerns. one thing which I can advise is all these patients, whether it's a male LUTS or female LUTS, try to bring in body mass index while examination. It's a good habit to mention the BMI rather than just mentioning the weight alone. You have missed to bring in chaperone during the third scenario. I mean, it's quite common, and I don't think the examiner will be able to pick like how I picking you, but just be careful. And then, because for the examiner you are just discussing only one scenario, okay? For
Yeah.
me, I know you very well, this has just happened by oversight. And
Sure.
as per the NICE guidelines, you are advising the patient lifestyle changes first and reviewing again. If you see the NICE guidelines, it is mainly designed from the GP practice level, of course for the super specialties also. So for the GP practice, it's always nice to tell them some reversible lifestyle changes and new lifestyle changes, and then unnecessarily not starting on a medication. But these things should have been done at the GP practice level, at the expectation, even though in real life it may not happen. So it is better for you as a specialist to start the medication in the first visit itself. The same thing applies even for the male LUTS table, because even though you can advise lifestyle changes, patient will lose precious 1 or 2 months and presence of symptoms. So it's nice to start the medications. You can tell the patient that you will need these medicines, but try lifestyle changes for at least maybe few weeks. If you're not improving, go to the GP and start the medicines, rather than giving only lifestyle changes, seeing a patient in 3 months time and advising medicines from the second visit.
A valid point. Thank you.
Okay, you can bring in NICE guidelines, and you can say, as per the NICE guidelines, I wish to do that. I hope the GP may have advised lifestyle changes, because that's expectation. Okay,
Yeah, that's
good.
fine.
We will complete today's session with these 3 scenarios. Any questions you have in these?
No, actually, these are quite good scenarios, but can we do some like urinary incontinence later on, maybe?
Yeah, that's the plan. So we will do one more female urology session with UTI, postmenopausal UTI, and second thing something like vesicovaginal fistula, and then we will do stress urinary incontinence as a 3 scenarios.
Very good. Yeah, that will complete most of the topic. Thank you very much.
Very good. Thanks for joining. Wishing you a good day. Hopefully, closer to the exam, we can do much more frequent scenarios, and we'll make sure we'll complete the whole syllabus at least twice before you guys go for exam.
Yeah, thank you very much. Really appreciate it. Thank you.
Have a nice day.
For you as well. Thank you. Bye.